Welcome to the Evelyn Y. Davis studios at the National Press Foundation. Coming up, I'm talking with two journalists who were on the ground covering Ebola in West Africa. What have we learned? Find out right now. The National Press Foundation is a nonprofit dedicated to helping journalists cover complex topics with depth and accuracy. Our mission includes journalists around the U.S. and around the world. I'm Linda Topping-Streitfeld, Director of Programs at the National Press Foundation. Joining me in the Evelyn Y. Davis studios is Gregg Zoroya, a journalist who covers war, climate change, and other existential issues for USA Today, including most recently Ebola. Gregg was in Liberia following U.S. military efforts to control the epidemic. Also, from a Google Hangout, we're linked up with Dr. Amy Maxmen. She's a journalist who covers health, disease, science policy, and evolution, among other topics. She returned very recently from Sierra Leone, where she was a fellow of the Pulitzer Center on Crisis Reporting, also covering the Ebola outbreak. Welcome to you both.
Thank you.
Thanks.
If you're watching live, we want to take your questions about Ebola and what we've learned. You can type them into the chat window under the webinar screen. Either log in or just sign in as a guest. I'll monitor the questions and we will get to as many as we have time for. This outbreak has a lot of lessons for different countries, people, institutions, and most of all for journalists. And I want to get to all of them. But let's start with what's happening now. I think it's important that we should be talking about this issue not as something that's totally in the past, because in West Africa it isn't over. Gregg, do you have an update on what's happening over there now?
Yeah, I could talk about it. There's no question that this is still very much an epidemic. I mean, it may not be receiving some of the attention it did in the media a few weeks ago, but there are people still dying, people still getting sick. The latest figures from the WHO show that more than 20,000 cases have occurred since the outbreak in West Africa, in the core countries of Guinea, Sierra Leone, and Liberia. And within that group, there's been over 8,200 deaths. There are definite signs of progress. The numbers are down in Liberia. Guinea seems to have plateaued, and the rate of increase, according to the UN, in Sierra Leone appears to be slowing. But this is all relative. The numbers that they have put out most recently show that in the last 21 days of December, there were 346 new cases in Guinea. Liberia, which is definitely improved, had 91, but there were almost 1,000 cases in the last 21 days, or the 21 days prior to the end of December in Sierra Leone. So there's no question that the problems are still there. They show some definite improvements in the number of burial teams, which is crucial to getting those bodies that are rife with the virus incinerated off the streets. And they have increased the number of beds per patient. In Liberia, that number has literally doubled to 14 beds for every available patient. In Guinea, however, the numbers appear to have fallen slightly, still about 2 beds per patient. In Liberia, there's about 4 beds per patient. So there have been improvements, there's no question about it.
It sounds like, though, this still in West Africa is a horrifying situation. Can either of you talk about what's happening in the United States right now? Are there any active cases currently in the U.S.? Amy, do you know the answer to this?
Not that I know of, but I don't know, so maybe I shouldn't talk about it.
Yeah, if there are any, certainly it's very, very few, and they're really under the radar at this point. We're just not hearing about it here. Amy, you just got back from Sierra Leone, is that right?
Yeah, December 31st.
So very, very recently. And you are in New York?
Yeah.
What are the rules there about quarantine? What are you allowed to do, not allowed to do, and how are you actually conducting your life over these next few days?
Yeah, actually, it's completely rational and it's well done. Because I'm low risk, I didn't go into any Ebola treatment units. I wasn't a nurse or I wasn't caring for anyone with Ebola. So I'm a low risk person. So what I have is a phone and a thermometer. And so I'm allowed to move about as I wish, but I take my temperature twice a day, and every day I get a call from the health department, and they ask how I'm doing. They ask if I have particular symptoms, and they check my temperature. So that's all I have to do. If I was to travel to another state, I just have to tell them about it in advance, and then they plan with the health department of that state how they'll keep track of me. But personally, I'm lucky because I'm freelance, so I can work from home anyways. I'm sort of just laying low, mainly because I know it's flu season, and if I got the flu, it would be terrible.
Talk about that for a minute. If you got the flu, you would have a fever.
Yeah.
And would that trigger more action?
So I don't know exactly what would happen, but yeah, I think, if I had a fever that was disconcerting, that's the first sign. So, and there's not a simple diagnostic test for the flu. So I think they'd probably take some pretty big precautions. And I've heard stories from other people who've come back that if they got sick, they end up being put into one of these high containment units and everything like that. So it's good they're being cautious. So that's why I'm just being cautious too, and not moving around that much.
Well, that makes sense. You sent us some slides, some great pictures actually from your time in Sierra Leone. If it's possible for us to cue those up now, I'd love to have you go through and talk about your reporting there. And I think that's going to raise some of the questions that we want to talk about as we go through this webinar. We want to deal with lessons learned from the global perspective, the global health perspective in the U.S., and then especially for journalists. And we're going to get to all of that. So I see, Amy, now we've got your first slide up. It's a picture of a cell phone with, talk about that.
All right. So, so I arrived in Sierra Leone on December 7th, and I had gone there. One of the stories I wanted to report was about these trials. There's different Ebola treatments, but one of the treatments that was sort of the most basic thing was using blood from Ebola survivors, and that had been tried in Democratic Republic of Congo, and 7 out of 8 people it was tested on lived. That's sort of an anecdotal number. So this was what they had decided they wanted to go ahead with. What I found out when I got there was, I arrived after taking the boat from the airport to the capital city, and I hadn't slept for 2 days, and I find out they're actually going to start right away. So they were starting actually the next day. So I immediately took a nap, and then I went out, and what had happened was they were going to start this trial in a week or so. They were still waiting for funding, but the lab technicians realized that the blood they had collected from survivors might go bad over, say, nobody really knows so much here, but maybe it wouldn't work as well if they just had it sit for a few weeks. Plus there's power outages. So they really were eager to just get started. So this is him on his cell phone showing me the bags of survivor blood they had collected, and that they were just going to go ahead and start the following day, even though all of the funding hadn't been in place for all 100 participants they were hoping to enroll in the trial. Yeah, and I think sort of the larger, in general, my experience in the outbreak was that things are moving quickly, and they're changing quickly on the ground. And so when reporting from the U.S., you're so removed from it, because by the time that news reaches the next person and the next person, everything's changed. So I could go on. I'll go to the next slide and just sort of give you a quick slideshow of my trip. So in this next slide, are you looking at that?
Yes, we've got it up.
Okay, great. Sorry. So the next slide. So the other thing I had gone to report on was this. Gregg mentioned the burials. That was, in the end of November, early December. The big thing was burials. There was the fact was people were burying their dead. They were washing them before they bury them. And there was other rituals that involved maybe hugging or kissing the dead, those sort of things, and and corpses are highly infectious, so that was a big fear. So I went there to report on these changing burial practices. That by the time I got there, I think by the time it was the beginning of the second week of December, it was actually pretty well managed, at least in the western area where Freetown is. So burial teams had gone in, they were able to remove the dead. The problems they were having were here, this is the main cemetery in Freetown, King Tom's, and it was full. They had already expanded it 3 times. And then if you go to the next slide, right behind this cemetery, there's this large landfill. So the big talk was about how can we clear the land in this landfill so that we can start putting bodies there. And that just gives you a sense of how rapid and how urgent all of this was. So now they have burials under control, but they need more land for all of the bodies.
And Amy, it looks from the picture like this landfill butts right up against a small community. Are these homes in the foreground?
Yeah.
Wow.
Yeah. Yeah, it's a dense city. It's Freetown's pretty dense. It gets a little bit thinned out around the outskirts and up in the hills, but there's parts down below that are the slums. So it's a dense area, and they didn't want to use all of the cemeteries. They only wanted to use a couple so that they can really keep their eye on. At this point, anybody who died was getting one of these safe burials. They don't want to take chances waiting for diagnostic tests to come back and all of that. So that was the situation with the burials when I was there. But then that sort of started, as they fixed this problem, people became very aware that, there was still a big issue with what to do with the living. So they had the dead under control, but then when you think of how to manage people in the very late stage of the disease, that's actually a lot harder because you have to get them, isolate them from their family members, treat them there, and then try and quarantine anybody who might have touched them. That's a lot. Those are a lot of processes. So that's actually a lot more difficult than burying a body.
Can you talk for a minute about what constitutes treatment in the late stage of Ebola? How do you help those people?
It's replacing liquids. I think that's the main thing they do. Is you're losing so many liquids, so it's just hydrating. And there's some debate now about how to best do that. If in the U.S. you would do that through IVs. There's some questions about doing that because every time you poke a hole in someone, you're exposing that health worker to the virus. So
interesting.
That's sort of the debate right now. But basic treatment is hydration.
Okay. Should we move on?
Sure. That sounds great. So to move on to the next slide, so like I was saying, the big issue was, all right, how do we handle the living? And in the very beginning of December, Freetown, a lot of areas of Sierra Leone lacked a lot of the holding beds to be able to put people who suspect cases. Towards around December 17th, a lot of these donations that you've been hearing about finally sort of came to fruition, and there was large treatment centers opening up. There was a lot of beds for the first time were available. There was more staff on the ground. And I think they added something like a dozen ambulances within the month. So this is the first time this country really has had ambulances going through the streets. Before that, people take taxis and motorcycle taxis to the hospital. So the next question was, all right, so how do we get people to change their behavior? Because before, there was a good chance if you called for help, nobody would come help you. So there was this thing that was launched on the 17th. The president announced it. It was called the Surge. And the idea was to just mobilize all of these people in the community to look for sick people and get them to the hospital. So what this is a photo of is I went out with a lot of these were like university students or medical school students who are patrolling all these different communities across the western area. It's around 2 million people. And what they were doing is they were trying to track down anyone that dialed this new helpline that was in place. The helpline was 117, and see, okay, do they have symptoms of Ebola? As it turned out, it was really, really complicated because people have been getting sick while Ebola's been going on. So there was people with cancer, people with malaria, people with stomach aches, drunks. People were dialing this number for all sorts of reasons. So this was a photo of a lot of the community people who were surveying the communities sort of meeting and discussing these cases and saying, should we call an ambulance for this? So that's what this is a picture of.
And
so
Amy,
just, yeah.
Amy, your story was fascinating when you described the idea that, first of all, there is no 911 service there, so people weren't really used to having an emergency number to call. And once it was provided specifically for Ebola, they were calling, as you said, for all these different things, including accident victims who then could not be transported because the rules were limiting those ambulances to only Ebola patients. It must have been very frustrating for them.
Yeah, frustrating, and you can see how important it is to have kind of a response, how much we take for granted our 911. I ran into a woman who had been lying on the side of the road for over a day with a leg that looked just terribly broken or mangled from an accident. But she couldn't get to the hospital, and the ambulances, these are new ambulances that have just been donated. They really are reserved, for good reason, for Ebola cases, but she couldn't get one of those, and then also
Amy,
taxi drivers didn't want to drive her.
Okay, sorry, we had advanced to the next slide, and you said ambulance, and we showed a picture of a motorcycle. I want to make it clear that was not the ambulance.
No, that's not the ambulance, although that's what takes people to the clinic often. But they, a lot of times, now at this point, both motorcycle and, taxi cabs as we know them, those drivers don't want to take anyone that looks sick now either because they're scared.
Right.
So it's kind of a massive problem. This photo, this is actually one of the surveillance officers going off into a community. Behind him, there's a sign that's talking about the distribution of malaria drugs. And a lot of people who were calling this number, it turned out they were getting sick because the government, with help from Doctors Without Borders and UNICEF, the World Health Organization, had distributed malaria drugs because what they wanted to do was knock down the number of malaria cases because, if that's a fever, it could be mistaken for Ebola. That person takes up a bed and they risk getting Ebola when they go to the hospital. So that's why they did this program, but there was sort of this unintended problems were cropping up. And just sort of an example of why it's great to be on the ground. I mean, my interviews with World Health Organization and Doctors Without Borders about this particular malaria program were more like conversations where I was telling them what people had been telling me, and they were surprised to hear it. So yeah. And then I guess finally, I thought I'd maybe end with just another example, this last slide with the girls. I went to an orphanage, and originally, when I had talked with UNICEF, the issues that they were having with some 9,000 children in Sierra Leone that have lost one or both parents to Ebola, the issues that they were having, they were talking about stigma and things like that. But what I found in this orphanage is they were talking about the problem. They've had 3 kids now that have entered the orphanage that turned out to be Ebola positive. And I mean, what a threat that is, because these are little kids. They all touch each other, and it could really spread really quickly in places like that. So I wrote another little story about this, about one particular Ebola survivor who is caring for a lot of the kids they quarantined. And I'll stop there.
Yeah, that was a very nice story, and it ended with the idea, I think, if I remember correctly, that this young woman had decided when all this is over, she's going back to school and wants to become a nurse. Yeah.
I mean, I'm stunned. I'm completely stunned how someone can suffer the loss of their entire family, their baby, and then just really be so dedicated to trying to help other people. Yeah. Within a couple of months of it happening. It's not like this is 4 years past.
Right, right. Well, thank you for that. It sounds like you did some great work over there, and the pictures are beautiful. Gregg, talk about what you were doing. You were in Liberia, and how long ago did you come back?
I came back in, I was there in November.
In November,
yeah.
So just a month before. It
Right.
hasn't been very long. You were there for 10 days.
Right.
Talk about what you were doing there.
Yeah, I wanted to mention, though, one thing I thought was interesting from Amy's comments. It was striking how many of the survivors wanted a future in healthcare. Some of the survivors are healthcare workers, of course, but other ones were hoping to train. But there was another side to it, too. I remember talking to a young woman at an Ebola clinic. This was the only job she could find. She was doing laundry there. She had survived, a young woman of about 22 years of age. And she didn't like to be there. It was a reminder of everything horrible that had happened to her. But it was the only job she could get, and she supported her mother. So there's really two sides to that. You can find people who are inspired, but also those who this is not a place they want to be connected to any longer.
Right. You could certainly understand that.
When I was there, I was focusing on coverage of Ebola, but with a kind of an emphasis on the military, the U.S. military. I've covered the U.S. military in Iraq and Afghanistan and elsewhere. And so there was an interest by my editors to find out what they were doing and how they were doing and the extent that they were doing it. And primarily the troops that were there, they were going to raise the level of troops there to about 3,000, which they got close to in early December. It's since come down. It's a combination of all service branches. Their jobs have been in three basic areas: to build the clinics that were needed, to provide the food, to provide the beds and the services that they need for the patients. And by the way, the United States focused on Liberia. Each of the countries has kind of a historical link to different Western nations. And so as a result, those nations kind of decided to choose, or they chose which country they would assist. The United States working in Liberia, Great Britain and Sierra Leone, and France and Guinea. And so the U.S. troops went to Liberia. They worked on building clinics there. They worked on training the staff members who would work in those clinics. And they worked to provide mobile labs for testing blood samples so they could turn around results of diagnoses much quicker than they were doing them.
How did it work? Sounds like a great plan.
Yeah, it was a great plan, I think, but it's one of those things where it's hard to know what's going to happen until you get there. You can try to prepare for it. They were very proud of the fact that they called themselves an expeditionary force, that they were able to land in this area that they hadn't worked in before and get things up and running. But there were a lot of problems. The roads, as you can imagine, were a disaster. They were there in the monsoon season in the fall when they were nothing but a sea of mud. They have ports there which are not accustomed to receiving the kinds of ships that were necessary to provide all supplies. So the military ships that arrived were the largest they'd ever seen in Liberia. It would take days to cover a distance that here in the United States we could cover in a matter of hours because of the road situation. So that slowed down the distribution of supplies, being able to get building materials to build these clinics in some of the outlying areas. So it was a slower moving process than what they had intended.
As it often is.
Yeah.
Talk about when the military actually got there. It's my sense, and we're backtracking a little bit here, this epidemic was well underway before Western governments and health departments really took notice. And WHO didn't declare it an emergency of international concern for a very long time. How much difference would it have made if the military had gotten there 3 months earlier or 2 months? Well,
I think it would have made a great deal of difference. I think they really didn't begin to gear up until the September-October timeframe. November was when they really hit their stride, and they were hoping to finally finish up in December. We're checking to see where they're at on that situation right now. But yeah, I think there's no question that in the areas where they needed resources most, which were in the number of beds to treat folks, and the ability to test those samples to understand whether people actually had Ebola or not, to protect both the healthcare workers and to protect those people who in fact weren't sick. Those resources just weren't there in the beginning. They weren't there in Sierra Leone actually in the more recent periods, which I think was a contributing factor for why the great numbers of infections and deaths that you saw peak in Liberia, particularly in the September-October timeframe, began to occur in Liberia more in the November-December timeframe. So yeah, there's no question that things could always have moved much more faster and help arrive in a more timely way.
Okay. For anyone who is just joining us, we are live from the Evelyn Y. Davis Studios at the National Press Foundation. We're talking about lessons learned from Ebola. I'm Linda Topping-Streitfeld, and I'm here with Dr. Amy Maxmen via Google Hangout, and in our studio, reporter Gregg Zoroya. Gregg, talk about the actual soldiers, the personnel of the military. Were they happy to be there? How did all this affect them?
Well, they were different in that sense. I mean, people who, when I arrived in Liberia, I flew in with a woman from Utah who was a nurse, and she was passionate about this. She had volunteered to come there. Most of the people that work there and deal with the patients, all of them, I believe, are volunteers. Soldiers aren't volunteers. I mean, they volunteer to join the military, but they're ordered to go there. And they took great pains, the White House did, to make clear that no military personnel would actually be treating Ebola patients. But nevertheless, there still is a great concern. And the soldiers came in thinking they would see a real disaster on the ground. They had seen the video from the media coverage of people dying in the streets, of bodies accumulating outside of the clinics, patients waiting there to be treated, and they thought they'd see the same. Of course, those things change over time, and by the time the bulk of the troops began to arrive, particularly in the November time frame, a lot of that wasn't there, or it was outside of their area where they were located. And so they were kind of surprised by that. It was an interesting dynamic for a lot of those soldiers. Many of them were combat veterans. These were folks from, for example, the 101st Airborne Division, who have fought in many battles in Iraq and Afghanistan. And so they were happy to be in a place where they didn't have to worry about roadside bombs, so they didn't have to worry about people shooting at them. And that was a very common refrain. At least they're not shooting at us here. Right. In fact, the reaction was completely the opposite, that the Liberians were just ecstatic to see the troops. They would salute them as they'd go down the street or try to greet them and talk to them in a very happy way. So it was a much different experience. And I really got the sense from talking to those soldiers, particularly the ones who were hardened combat veterans, that they were much more relaxed, that this was a place where they could just kind of take a breath and just do their job.
Right, and feel like they were really helping people.
That was a big part of it, I think. They really thought that this was a war that they were winning, that things were getting better at.
Right. It's interesting when you talk about how they were surprised at how relatively good things looked on the ground when they got there because of the media images they had seen. And Amy, if you're with us, I know you did a story you did a slideshow that was published somewhere that you introduced by saying, I want to show you the 99%. So there's a small portion of this country where things are really terrible, and that's what you've seen over and over again, people in hazmat suits and people grieving at funerals, but let me show you what else is there. And
I guess I should clarify. Oh, sorry.
No, go ahead.
So that was a slide, it was a slideshow for Scientific American, and I should clarify that it wasn't that people weren't feeling horrible things, because it was horrible for everyone. Everyone who's Sierra Leonean. It's a horrible thing, only it wasn't because of a hazmat suit. It was horrible in other ways, like horrible because their businesses are failing, or horrible because they haven't seen their family members. So it touched people in ways that I felt like weren't covered, whereas I think here, we only see photos of people in hazmat suits. So I guess I wanted to show what people were doing outside of the hazmat suits and how the outbreak was affecting them.
Yeah, I think that was important and a good thought. Is there a lesson there for journalists? We know when we go into a war zone, we're going to show pictures of war and battles. And we know when I was reporting in Miami decades ago, we were going to show pictures of riots. And so for the rest of the country, Miami was all about riots. Iraq is all about war. I guess that's our job. Is there any other way to look at it?
I think it's a tough one. I think this is the story that this is the reason why people are reading the stories or watching the videos, because they're interested in Ebola. Mm-hmm. And so you tend to show them what's happening, and it can be the worst of the images. I can remember I had a chance to interview Liberian President Sirleaf, and she was acutely aware of the image that her country had around the world. She talked about how they had become the poster child for medical disaster, and she didn't like it. There were restrictions that had been placed on allowing journalists finally to talk with Ebola patients in the clinics, and also obviously they were trying to get those bodies that were out there off the streets as quickly as possible. A very keen concern about how they came across and how it looked, and I think this is something that without question. I think it's great that Amy showed the other side of that story, because that is something that often really gets lost in all the histrionics and the really hard coverage that occurs out there.
Yeah, absolutely.
I think I try and think of, and maybe this is a question for all of us as journalists, how to get people to care. I mean, this is undoubtedly a horrible thing, so I think a lot about how to get people to care, and I think maybe at some point, if all they see is this figure they can't really relate to, and it's just so horrific of a dying person or something, how long will they care about that person? Maybe they'll care more about someone they relate to a little bit more, like this teenager in an Angry Birds shirt at the orphanage. So anyways, that's something I have in the back of my head when I report too.
Right. Right, makes sense. Can we go back for a minute to the very beginning? Why do you think it took so long for this epidemic to be understood internationally, and for major countries to really begin trying to bring it under control? What took so long? What happened?
Well, Amy's probably got a good handle on this as a medical person as well. My understanding is that this disease was unheard of in this part of the continent. That Ebola really was something that had cropped up in the central part of Africa, and so there was, first of all, kind of a skepticism about whether it could even be there, and then there was, I think the New York Times has done some terrific reporting recently showing that there was some miscommunication in the early months about where the infections were and whether the infections that had crossed borders existed in Guinea after they were, or in Sierra Leone, and so there wasn't, people weren't talking to one another and telling them where these people were located, and so the steps were not taken.
Right. So what is the lesson from, I mean, I think what we're saying and what we've all been reading is that there were a lot of communication problems between health leaders in country and the World Health Organization, communication issues, failure to coordinate efforts. Did you see evidence of that?
I did. I mean, when there finally began to be a tremendous outpouring of resources into Liberia, when things began to turn around, it was almost in an uncoordinated fashion. I mean, I can remember when I talked to the President Sirleaf that she said, she admitted she didn't even know exactly all of the host countries or what all the host countries were doing in her nation and what they were building and who they were treating. There was a lack of coordination there. I mean, I think when you talk about lessons to be learned, it seems like this was a time when this was an Ebola outbreak that we'd never seen before. So I mean, the world has really gotten burned by this, and you would think that organizations like the WHO, which has come under criticism for not responding fast enough, might learn the lesson that there has to be a more aggressive effort, that they can't be concerned about the political ramifications of asserting that this has the potential to be a very dire epidemic and move more quickly. You would like to think that would be a lesson that would be embraced.
Yep. What about Doctors Without Borders? They seem to be the one group that tried to raise the alarm early. I felt from the coverage over here that they were everywhere. Amy, did you deal with them at all?
Yeah. Well, number one, they actually were the international group that raised the alarm about this fairly early on. And it was the director of the WHO didn't listen to that, from what I've read, for months. And also they stayed there, whereas initially there's in Sierra Leone, there's many NGOs that have been there since the war, so for the past 10 years. they left, and the reason they left was because they don't have experience. So it's good. They don't want to put the people that work for them in harm's way. So they evacuated the country. Doctors Without Borders stayed there because crises are that's their thing. So they buckled down. They had been involved in other outbreaks in the past, so they had experience with the disease, and they had experience in working in emergency situations. So they stayed there and they raised the alarm. So in my mind, they're good on both of those levels. And as far as the response being slow and disorganized, which it has been, part of the trouble also is that some of the NGOs that then came back to set up clinics and start dealing with Ebola, they have no experience in this. So that's one reason why there was delays also. For example, Save the Children in Sierra Leone, their first clinic was supposed to open much earlier than it actually did, and they held out for a while, and then finally opened, and one of the nurses got infected. So there was people dealing with this disease that had never dealt with it before. So yeah, perhaps there should have been better leadership.
So does all of this, what does all of this say about the need for improved healthcare infrastructure in these countries?
Well,
I mean, the fact that Doctors Without Borders has to go in there and their reporting systems and so forth, how do we solve that?
It's a good question. I mean, I only hope that some of the donor funds that are being put towards this end up contributing to the public health, the system that's there. Because when it's just Doctors Without Borders is wonderful, however, they're not the public health system. So, and same thing with these NGOs. A lot of them were doing great health projects, but when they left, those just go away. So, and I think there are discussions going on right now between World Bank, WHO, to talk about how to contribute to the public health infrastructure, because really that's what the problem was here.
Public education is obviously key to controlling an epidemic anywhere. There were cases over here where it did not work well, particularly early on. Talk about how that worked and what the lessons are in terms of educating the public about the disease.
Well, I know one of the greatest, the one major regret that Liberian President Sirleaf had when I talked to her, and she was very defensive about the criticism that had been received, that she hadn't moved quickly enough to close the borders when the disease began to really become serious. It hadn't moved quickly enough to consolidate a response. But one area where she admitted she had regrets was in education, that there wasn't enough done soon to inform those people, particularly in the outlying areas and the tribal areas, where they thought this wasn't a disease, but that it was possibly witchcraft, or that it was some kind of a conspiracy by a government that, in many cases, these outlying areas had been under tremendous pressure from the central government during periods of intense revolution and infighting and combat that occurred in these countries in recent decades. And so there was a lot of suspicion about the government, and this caused a problem with them trusting what was being told to them. And she said that was an area that where people simply died because they didn't get word out there about what this could do to them, or they didn't do it effectively.
Right. We actually have a question coming in about how the disease is transmitted, which was a basic problem in this communication, which we're just talking about. Can one of you just address that very basically? How do you get Ebola?
Yeah, so the simple answer is it's transmitted through bodily fluids, so sweat, urine, vomit, diarrhea, blood. But I think, but the reason somebody would be leaking those fluids would be because they're very sick. So initially, the virus, when you're first infected, the virus is at a very low level, And then once it multiplies, that's when you start having these symptoms like a fever, and not a fever of 99 or 100 degrees, but a very high fever where you're just dripping sweat, and you're vomiting and you're leaking fluids. And then at that point, it is very infectious. So then if you're in contact with somebody at the late stage of their disease, or just after death, that's when these fluids are around them, and then that body is very infectious. But early on, before a person's leaking these fluids and before they show symptoms, everything we know says they're not infectious.
Right. And there's a follow-up question, which is whether you can get the virus from touching the clothes of an infected person.
I mean, the real answer is I don't know if there's a real study on that. I would imagine, just guessing, if it's the very late stage of a disease, I personally wouldn't want to touch anything that person's been in contact with. But again, that's the very late stage.
Right.
As far as before that, I don't think so.
Right. I want to talk briefly about one of the really tragic elements of this epidemic, which is the devastating loss of health workers. Because the easiest way to catch the disease is when you are treating someone who's very sick, as Amy just described. I think thousands of health workers have died, and these were in countries where they didn't have that many health workers to begin with. What's the impact of that, and what's the lesson from it? Anybody?
Well, the impacts, for the reason you said, they already there was already too few health workers, so the impact is horrible. I think while I was there, two main doctors in Sierra Leone died. That makes it 10% of their doctors have died. One of them who died was actually a doctor who had left and gone to London and then returned to help out. So that's, he volunteered to come back and help his country. So it's incredibly tragic. The beginning, there was even, I don't know the numbers actually, but initially, when in the early days, I think it was an even worse state of affairs than it is now, though, because when people didn't really realize what Ebola was and how to protect yourself, I think it was really horrible then. There was stories of ambulance drivers not wearing protective gear and things like that. Hopefully next time, at least there'll be more knowledge about what you need to do to protect yourself as a health worker.
I don't think there's any question that it's been devastating to their healthcare systems. I mean, I know that, for example, in Liberia, they were just, their healthcare system was kind of just getting its legs under it when this struck. They had about some years back, 3 or 4 years back, I think only 1 out of 4 women who were giving birth had doctors to assist them, and that had risen in 2013 to 2 out of 4. So there was some, even then it was not a great history, but they were making some improvement, and then when this struck, that obviously brought them to their knees in terms of the healthcare system. I think something we talked about earlier, that there's a lot of young people who are inspired to get into the field of medicine by this, might be one kind of silver lining to this, but then as Amy's indicated, there are the real veteran, knowledgeable doctors that have been lost in this epidemic, and that's something that takes a long time to replace.
Right. What about in the United States? We've talked about the difficulty of treating this disease and health workers staying safe in a place like Liberia or Sierra Leone, Guinea. But in the United States, we also infected a couple of health workers after the CDC said any hospital in the United States can handle an Ebola infection. Turns out we were wrong. What are the lessons there for the U.S. health system?
Yeah, I find that's kind of unforgivable that those nurses were exposed. The lessons are, I guess not to be overconfident. This is a very infectious disease in the late stages. So hopefully that lesson's been learned, that now that won't be happening now, and that nurses will be fully protected and fully educated. I'm not sure what happened all the way, but I would hope the CDC would be deeply involved. They are now with me. What's reassuring, I guess, is I think the system they have in place now, nothing will ever completely block these things from happening. But the system to me seems fairly sound.
Mm-hmm. What about this issue of stigma? There was a lot of panic in the United States when health workers were getting sick, when the first couple of patients were coming over from West Africa. And that resulted in a lot of stigma against people who had visited in West Africa or had various other types of contact. Has that changed now? Is that gone in the U.S.?
Well, I think in the U.S., it seems like there's, when I came back in November, I didn't get a sense that there was the same sort of, well, certainly there wasn't the kind of panic that you got a sense of when the infections occurred previously in Dallas and so on. But I mean, I think, and people seemed to respond a little more reasonable fashion, although they were still kind of, you could tell that they were still kind of, there was an off-putting aspect about how they viewed me when I came back and whether I might be a carrier, even though it was really a remote possibility. I think what I witnessed in West Africa was that there was a kind of an evolution in the stigma. That in the beginning there was a desperation to get treatment, to get these people health care and try to help them. And then, as particularly in Liberia, and this might be what ultimately happens to Sierra Leone and Guinea, there was really a social desire to want to put this behind them. Liberia, the number of cases has dropped dramatically, and I wrote about this in a column that I produced while I was there, that there's a real effort now, particularly in the capital of Monrovia, to just want to get this away from them. They don't want it around them any longer. They've dealt with it, and they know that it separates people, and they just want it put away. And it really, you can't do that in this society quite yet. You have to be more understanding and educated about it. But I mean, it does create terrible stigma still, and divisions within communities. If you have even as the disease begins to wane, if you have cases that crop up in communities, it can cause even anger that healthcare workers come in or burial teams come in and try to remove bodies, because it then casts a pall and a stigma over that entire community, and they don't want that anymore. They want to get away from that.
Right. Let's move now to really talking about lessons for journalists out of this. You both have been involved in covering this on the ground. You've got great stories. Amy, I'm going to start with you, if you're still with us.
Yep.
Talk about how you operate in a foreign country that's in the midst of an epidemic like this. What's important for you to know as you're going about your day-to-day work?
I think, for me, it's to really make the most of the fact that I'm on the ground. So, for example, if I talk to someone from the WHO and they tell me there's going to be a trial that's starting using survivor blood, I want to talk to the people collecting the blood. I want to talk to the survivors donating the blood. I just want to talk to people and see how they feel, and I try and make use of that opportunity all the time with anybody I encounter.
Mm-hmm. All right, make the best out of being on the ground. Greg, how about you?
Yeah, no, that's exactly right. I mean, there's some basic practical steps in a situation like this that any journalist has to take. They have to be careful about not touching anybody. They have to be careful about washing their hands, even monitoring their temperature on a regular basis, not to ride in taxis because they have been used to carry bodies, or just kind of be mindful of the risks of transmission of the disease. But the real stories are unquestionably with the people, and being able to sit down with them and take the time to understand what they've been through, and it's just basic nuts and bolts journalism, and it really produces the strongest kind of stuff you could possibly get. I mean, when you finally get a sense of where they're from, where their passions are, what their dreams were, what the dashed dreams are, who they've lost, how it's changed their life, all the kinds of things that every journalist can learn or understands in any situation. I mean, particularly in these kinds of, this has been my experience in even covering combat. When you get into these kind of extreme human circumstances, the stories are just bubbling up everywhere, and it's just a matter of doing your work.
Now, you talk about nuts and bolts journalism, but I know that both you and Amy were doing a little more than nuts and bolts, because you were tweeting and shooting video and recording audio and probably had a notepad stuck somewhere. And what was that like in this open situation to try to manage all the equipment and all the demands?
I can add to the list too.
Go ahead.
I joined Instagram really just before I came, and I really liked Instagram. I actually learned an appreciation for social media that I liked the instantness of it. I guess for me, I liked all of the demands because the situation was moving so fast, and there was so much to take in that I just there was so many stories to tell. So if there were ways I could even just get out little things quickly, like on Instagram, just shooting a photo and giving it a caption, I enjoyed that. Yeah.
Well, that's great.
I didn't feel like there was too much. There was only too many stories that needed to be told, and it was just
So
the more ways I could tell them, the better.
You really appreciated all the platforms and opportunities you had to tell stories in different ways.
Yeah, I didn't shoot very much video. I've done that on other trips, but maybe that was just one too many for me.
Greg, how about you?
No, it was. It was a real kind of a journey of understanding for me. As an old shoe leather reporter, where I'm used to communicating in the written word, it was a different experience. I did, and what was most interesting was. It was busy. I mean, you'd spend the day reporting, and then you'd come back to your hotel and spend the night, running out string on all these different platforms. But I was surprised by the response on some of these. When I did, we shot video as well, but the bandwidth was difficult. It was hard to send that back. So that really ultimately wasn't doable until I got back to Washington. But the audio could be sent out, and it could be put together with by an editor back in USA Today. And some of the strongest response that I got from the work that I did was with the audio coverage, was the ability to hear these people talk and explain their stories, or just in my kind of describing what I was seeing. And I was really surprised by how people responded to that. Twitter was something I used obviously quite heavily, and I got more retweets, hundreds of thousands on this trip than I've ever had before. So it was really it was very satisfying, and it was interesting that you could reach people in so many different ways with such an important story.
Right, fascinating. Thank you so much, Gregg Zoroya, Amy Maxmen. Really appreciate your having been here.
My pleasure.
And for those watching, next week's webinar is going to be writing about healthy food and eating well. You'll find the schedule at our website. Sign up for our newsletter. Use the donate button on the homepage. And thank you for joining us in the Evelyn Y. Davis studios at the National Press Foundation, where we are making good journalists better. Special thanks to Bayer, which provided funding for this webinar.